button and get going. All right, if you can move us to the next slide, Olivia. Perfect. So as you all know, we are here for the purposes of advancing the science and recovery community centers. And our goal is to bring together the different stakeholder groups that are impacted and are related and have insight into how best to do this. This is our steering committee that has been guiding this project for all this time. And if you can go to the next slide for us. We also wanted to mention that we are also part of a larger group of people who are not just focusing on recovery community centers, as we do here, but more generally on addiction recovery science overall. And there's a lot of stuff here, which will be in the slides we'll email out to you all afterwards. So if you have any questions about any of these organizations, opportunities, people to meet, we're always happy to make introductions. So if you read this and you see something you like, reach out to us and we're happy to chat and connect you. At this stage, I also want to mention to everybody that we do have our deadline for our own pilot study program today, December 1, and we're getting some very exciting applications in. And our next seminar will actually not be in January. We always skip January. It'll be in February, and Ellie will put the registration link in the chat for us. And that will be the introduction for our newly funded teams. So the teams that are going to get funded to do their pilot study project will be presenting in February, and they will come here to this group to each say, this is the project we have in mind, with the goal of hearing from everybody here about thoughts they should consider. What should they keep in mind? How can they improve the design? Feedback overall, so that this group can help inform those pilot studies. And then, of course, once they're done, they're going to come back and present the actual results. But in February, you'll get to see what the projects are and contribute to them by providing feedback to the investigative teams. All right, moving on to our live feature. As you know, we always start with our live feature to really ground us in what recovery community centers are. And we are very happy today to have with us Brian Robbins from CCAR, and he's going to tell us what it's like when you walk through the door of his RCC. Brian, take it away, please.
Thank you, and good afternoon, everybody. I was thinking earlier, I was going to do the script of, what happens when somebody like new or first enters into our center. But I was driving into work today and we've been expanding our hours in our services at our centers lately. So I've been working a little more in depth within the centers and some extended hours training evening staff and weekend staff. So I had a great conversation with one of our volunteers in our center last week, and it just came to me this morning, and I want to share it with you. In our Hartford Center, we have a gentleman, one of our volunteers. I mean, this person has struggled with addiction in the lifestyle for over 30 years, and in and out of jackpots and, jails and prisons and things like that. And, he started coming to our center about 4 or 5 months ago. And, he's and so I had a conversation with him the other day, because I seen him walking up to our center, and he looked like he was stressed. He was stiff. And when he walked in, he sat down in the front of the center right near reception, and you kind of like just seen him just get comfortable. So, there was a few of us around, we were talking, we were engaging. And so I asked him, I said, how you doing today? How's things going? And he goes, better because I'm here. Right. So, and leading up to this day, we had prior conversations about, he really didn't know like what he was looking for. He didn't really know like, what really motivated his spirit. And he had a little fear around like, trying new things. So we have some groups that are in our center that some holistic groups, some mindfulness and things like that. And come to find out, these are the things that he's interested in. And because he was with his peers and with community within the center, he had the courage to start to go into these groups, So now, that night that he came in and he was a little stressed out and everything, we talked. And then he got up and he went into one of the group rooms, and I noticed, I walked away, I did a couple things, and I noticed when I went back, he was sitting down with him and another volunteer, and they had these adult coloring books, and they had the colored pencils out, and he was sitting there coloring. He had his headphones on, he had some light music going on, and he was just coloring. So afterwards, he was sitting there for about a half hour, and our yoga group was coming in. And this is something that he had found for himself, that he had just started to participate like 2 or 3 weeks ago. And he is finding that this is what really fills his spirit. He's finding some things that he never thought that he would engage in, that is really what interests him. He's finding community, he's finding himself, and through the support with others in the center, he feels okay to walk into those groups. So now when I see him, I go into the group. On the last evening, I was working in the evening, he was participating in the yoga group. He was going to our drumming group that we have on Wednesdays, and the look on his face and his posture when he leaves those groups is like of total freedom. Like he is centered, he's in his space. So I asked him about it. I said, so how is those groups working for you? He said, Brian, let me tell you something. He said, I know you kind of know where I come from. I come from the lifestyle. He's from the south side of Hartford, grew up on the streets, and suffered with his addiction for over 30 years, in and out, and never being able to find something that really worked for him, that fed his spirit. He goes, I don't know what exactly happens when I sit in on that yoga group and that drumming group, but all I know is I'm going to continue to go, because when I leave there, it's nothing that I've ever felt before in my life. So we started to have a conversation about mindfulness and meditation and yoga, and about how to continue to expand and to explore that. And I'm going to see him tonight. So I'm going to see how, because I was telling staff in the center, I said, so these are the things that we pay attention to when people come in our center. This is what happens. Our centers, we believe our centers are recovery sanctuaries, and transformed people transform people. So I believe that this volunteer is in that process. So now the conversation that continues with him is like where we pick up from where we last left off. So he's exploring, he's reading, he's searching on the internet more about mindfulness and meditation and yoga and these experiences, and because he's finding that this is what's working for him now. So when you ask me that question, like what happens when you walk into a recovery community center? Transformed people transform people. That's what happens. Exploration, community, recovery, right? So that is what really excites me about the work that I do. Because if it wasn't for me being in this expansion, I wouldn't be covering a lot of these hours. I'm in the center a whole lot more right now. I'm actually sitting in our brand new center in New Haven that we just moved into yesterday. So I've been a little more able to sit back and engage with volunteers and participants and have those conversations. And the conversations that I've been having are beautiful. They're beautiful conversations that I've been having. So I'm really excited about this movement. I'm really excited about the volunteers and the participants that are finding recovery, the ones that are seeking recovery and finding themselves, and finding what really touches their spirit that allows them to get another day, and so I will keep it brief because I can be long-winded. But I appreciate everybody listening. I appreciate being invited, and I hope that story touched somebody, because I know it touched me. Thank you.
Wonderful. Thank you, Brian. It's a totally vivid image that I think we're going to be taking forward and keep in our minds when we're thinking about what happens when you walk through the doors. And I like those coloring books too, by the way. I love those.
Yeah.
All right. Olivia, if you could move us to the next slide. So as you all know, we always include polling questions to see who's in the room and to see who we need to reach out to get into the room. So if we can start the polling questions now, they're going to include our usual, who are you and where you're from kind of questions. And then we have questions to preview the topic of today. And just as a disclaimer, they will seem, the last 3 questions are going to seem very wordy to you, but it's basically the same question with 3 different stems, where we're going to be asking, what is the most common setting in which peer recovery support services are being delivered? Which one of those settings, same settings, is the most challenging, and which one is the most optimal? So even though you'll see a lot of text, just keep in mind they have the same choices, just the stem is different. All right, I'll give you a moment to fill this out. And then when you're done, the submit button should turn blue. Olivia, how are we looking for percentage completed?
We're at 65%.
All right, we'll give it some more time. And Brian, while we are waiting for some responses, a random aside, our team has been looking at smartphone apps and if they can help people with recovery and what's available in the public market, and mindfulness apps, like the apps that actually assign mindfulness exercises and gratitude journaling. It's not a lot of apps, but there are some apps that are starting to do that, which is exciting and links with what you were seeing. Of course, it's a very different thing to do it on an app and walking through a center and being surrounded with people who are role modeling, who are opening your eyes to it, who are giving you ideas for how it can look and feel like. Just that was on my mind when you were talking too, that we're seeing those tools in that space as well.
Okay. We just hit 81.
Very cool. All right. If anybody wants more time, or did you already click it?
I already clicked it. Sorry, guys.
That's all right. So here we have it. We'll jump down to the ones, our questions about today. And you have a little gray tab on the window where you can scroll down to the things that you're most interested in. So in terms of, I believe that scientific research can help inform which one of the following things. And we had most people saying that it can help with the quality of RCCs, but also the development. And then we still have a lot of people saying that it also helps the impact that RCCs can have, a social impact, and can help support the availability of RCCs as well, about 75%. Then I see 6% who put some answers of other. And let me just see, did you guys get a chance to put it in the chat about what was on your mind when you said that? I don't see them yet, but if you do get a chance, please do put them in the chat. We'd love to hear whatever impacts you have in mind. All right, and now we have the most optimal setting, most challenging setting, and the most common. So the most common, we had 56% of us saying that the most common setting in which peer recovery support services are being delivered are in community-based settings, such as recovery community centers and recovery community organizations. And that is true. That's what Ken Smith will tell us about in a little while. That is what research shows. In terms of does that line up with which one is optimal versus most challenging? For most optimal, 90% of us believe that the community-based settings are the most optimal. Makes sense. We're all here because we care about RCCs. And we thought the most challenging setting would be emergency departments and the criminal justice or corrections settings. All right, perfect. Thank you guys for filling this out and setting up our main presentation. If you can go to the next slide. We have with us today Dr. Ken Smith from the University of Tennessee in Knoxville. And we invited him because he wrote what is a report from Faces and Voices about unlocking the potential of recovery community organizations and peer recovery support services. And we wanted to know, well, you know what things are on your mind when it comes to unlocking the potential. We want to know how science can help. So we asked him to come here and talk with us about these issues. I will also add that after when Ken is going to talk for about 20 minutes, and we're going to hold our questions until right after he's done, and then we'll fill in those questions. And then we have with us two discussants, including Brian, who you've already heard from, to kind of share their thoughts and reactions to what Ken has said. And of course, at that point, everybody else, please also chime in with your thoughts and discussions. All right, without further ado, Ken, can I turn this over to you?
Sure.
Thank you for being with us.
All right. So is someone going to turn my slides for me? Because I can also use my
Yeah,
slides.
I'll be flipping through the slides for you.
Okay. Next slide, please. Because I can't see my notes on my slides without that. So first, let me just give a little background that, I was invited because of the paper that I co-authored with Robin Peyson and Sierra Castedo de Martell, who all of you may know because she is one of the grantees. And Robin asked me to participate in this paper because she was working with a group of EDs from recovery community organizations about understanding what the best methods are for financing peer recovery support services. Please keep rolling. And it turns out that when she brought me on, and I'm a health economist and I study healthcare systems and financing, that it was a little bit more complex than that. It's not just a matter of increasing reimbursement rates. And in fact, there are a lot of other broad issues involved. And so what we saw was that there was a need for broader systems change. And so we came out with this document, Unlocking the Potential of Recovery Community Organizations and Peer Recovery Support Services, as a way of starting dialogue to think about some of these very complex issues. And these are some of the things that we found. First of all, could you please go to the very end of the So we found that unfortunately, a lot of peers are working in conditions that really limit their ability to deliver peer recovery support services, or PRSS, at optimal levels. And we thought it was really important to think more about the environments in which they work, particularly protecting the fidelity of the model to recovery principles. And we thought that we needed to have greater concern, not just for participants in PRSS programs, but also the peer workers themselves, because they are also people in recovery, and we don't want them to be in stressful situations. And so peer workers and recovery-centered organizations, we think, have a big role to play. And I'll say a little bit about what I mean by recovery-centered organizations. Next slide, please. Well, let me just end that we also talk about the need for more multi-sectoral collaboration, particularly with public health, in order to affect change in these broader systems. And then, recently the Foundation for Opioid Response Efforts came up with a survey that basically verified a lot of the things that we were saying about the workforce. Please keep going. So I'm not going to say very much about this. I was asked to think about and present what we know and what we don't know that should be a subject of investigation. But I wanted to give you an idea of the lenses that I used when I thought about that. I am a health economist. I'm also a systems thinker. But my current scholarship is around social movements for recovery, harm reduction, and mental health. And I'm interested in how these social movements bring about larger transformative systems changes that affect culture in the broader society. And that involves leadership. We have agency. And so what I do is I study organizational decision-making, particularly strategic decision-making around programming and this programming for, say, recovery community centers, and also, whether or not an RCO might want to open up a community center. So next slide, please. So I just want to be clear about nomenclature because it can be a little bit confusing, and it's been confusing to me as well. It's important to be conceptually clear as scientists about organizational form, and we do have these definitions. I won't read them, but I will just say that for me, what's really important is that RCCs are recovery operated. I'm interested because they all come out of movements. We see a wide variety of organizational forms, but what's really important for me is first that they're either recovery led, recovery governed, or recovery operated. And then the second thing is who's making the decisions. So it's possible that a group of social entrepreneurs in a community can lead an effort to develop a recovery community center. But it's also true that a recovery community organization can decide to open up a recovery community center in a community, in a particular place. But if that's the case, there's sort of overlap. There are two organizational structures that we can think of, but the board of directors is the same. So is it an RCO, is it an RCC, or maybe it's both? And so I'm going to use the term recovery-centered organizations when I'm talking about all these kinds of organizations together. So you'll see a little hyphen there in my slides. Next slide, please. So the first set of questions that I have are really around workforce settings and outcomes. So we do know that peer recovery support services is evidence-based, and it has a wide variety of positive outcomes such as reduced reoccurrence of use, improved quality of life, and so forth. But we also know that it's being increasingly delivered in settings across the care continuum. But we also know that there are a lot of workplace issues that limit peer coaches' effectiveness, such as workplace factors like whether or not your organization understands recovery, whether or not you have a supervisor that understands recovery. And in those cases, people may be confused about what their role is and not self-disclose and form that bond and that relationship with the PRSS participant. And that, of course, can cause stress, or because we know that the lack of control with high demands leads to stress. And so if you're in a workplace where you have a lot of tasks that have nothing to do with being a peer recovery, a certified peer coach, and there's no role clarity, that's very stressful. And ultimately, it may lead to turnover, poor job performance, and things like that. And so that's what we know is actually happening. But next slide, please. It would be interesting to understand that phenomenon in more detail. I think it would be interesting to know what role does the setting have on the quality and outcomes of PRSS and the practices and strategies to optimize them. How do all these different RCOs, many of whom provide PRSS, how do those settings differ in their delivery, in their delivery quality, in the outcomes? And what are the unique benefits of these recovery-led, recovery-governed organizations that are different from other settings that are not? And how can RCOs collaborate and coordinate with these other stakeholders? Is there a way that RCOs can sort of help to ensure fidelity of the model or protect the well-being of peers that are in these other settings? I don't know. It's a question. What are some strategies? And is there a way of doing? How do you tease out these things? This is more of a methodological question in the data. How do you tease out these different effects of the setting and model fidelity? I think that would be very important. So let's go to the next slide, please. So the next set of questions are really about measurement and the mechanisms in which PRSS affects outcomes. So it would be interesting because we do know that PRSS has these multiple pathways. I mean, there's a motivational and relational aspect. You know, there's the skill building, there's the matching with resources and things like that. But we also know that there are pathways that affect peer workers themselves. In some cases, some of the outcomes may be very positive. Other cases that might be, because we do have incidences of stress, burnout, and compassion fatigue. Next slide, please. So the question is, you know, what are the relative magnitudes of the effects of these different mechanisms or components? How do you even capture the peer participant dyad relationship? I mean, what's a good measure of the quality of that relationship? And how do you determine how that relationship ultimately traces out to achieve an outcome? And what's the relative difference between that effect and other kinds of effects? And so what ultimately are the long-term effects of peer recovery worker of being a peer recovery worker on the peer recovery workers themselves? I don't think we know that. But that would be an interesting question. I mean, are they moving to completely out of this workforce? Are they moving up the career ladder? What's going on with them? Next slide. And community recovery and RCCs. Now I'm going to start getting specifically to recovery community centers, because I think that they have a very important role to play, not just in recovery, but also in what I think is important, which is rebuilding or reweaving the fabric of community that often has been torn asunder by high rates of substance use and other things. And so we know that RCOs, recovery community organizations, aim to foster a culture of recovery, reduce stigma and discrimination, and promote inclusion in a supportive recovery community. They do a lot of advocacy. But RCCs, you know, also offer a stigma-free environment for people entering recovery through their programs and events, like yoga, like the yoga and mindfulness classes that Brian was talking about. And they deliver these services, and they're not just individual level. These coaches are forming, yes, individual bonds based on vulnerability and authentic relationships based on trust. I mean, that's a part of what they do. But over time, they're building a whole network of people that have been impacted and that have been impressed upon by that authentic relationship. And those networks of people that have been part of a caseload become a part of a wider community. And so, you know, we talk about the fellow that Brian was talking about, but I think that those relationships and the beneficial effect on that individual may reverberate across the community and beyond just the community of people in recovery? I think that's a very interesting question, because a lot of what peers do and what recovery RCOs generally do is they help to enhance social capital and civic engagement, which can improve public safety and quality of life, not just for the people in recovery, but their families and their broader community. And it would be, and of course, like I said, they built these trusting relationships and these networks. That's all part of a larger community. And we know that social cohesion is important. You know, the CDC has been talking about loneliness, and these are very serious issues, not just for the recovery community, but for society in general. And Healthy People 2030 now has a set of goals around improving social cohesion, you know, our bonds of trust and community. Next slide, please. And how am I for time?
You have 1 minute to the 15-minute mark.
Okay, great. Okay. So the third set of questions is really about community recovery. And let's actually let's just go to the next, skip to the next slide. And then I'm going to just go over some of these questions about community level recovery. So if anyone, if you guys are up in the literature, I would point to an article that author Evans and William White did a while back about this whole concept of healing whole communities. And William White also did a paper about this concept of, you know, the wounded healer and wounded communities, particularly with respect to indigenous communities, and why it's really important to think of the whole community rather than just individuals, which, you know, freedom-loving societies like ours love to really talk about. But I think that we really need more rigorous and comprehensive research around this issue to evaluate the community level outcomes. What's really relevant and meaningful in community level outcomes and indicators? How do we measure it? You know, how do we evaluate it? These are the kinds of things that I think that would really move the movement forward, as well as answer some legitimately critical questions about society and what we can do to improve our society, which has been very fractured and is losing a lot of the bonds of trust that are needed for a functioning, healthy society. Next slide. So I'm on almost done, and I could probably stop here. And so remember, I'm interested in the behavior, the decision-making behaviors of executives and leaders. And so, you know, as I mentioned, it's these decisions that really make a difference. Ultimately, we need leaders to make decisions about doing the things that we're doing. Having programming that working with people in their community, the recovery community, to decide as a group what kinds of programming would be necessary. The decision to take that perspective on how to decide what kinds of programming is effective is a decision itself. You know, you could decide that you're going to just do something because you think it's the best practice or useful, or you can talk to people that would go. That's a decision itself. And so I'm interested in why people and how people make those decisions. And next slide. So what I think would be useful in research is to really determine how RCCs assess and respond to changing needs and characteristics of the communities, and how to adapt and innovate their services and programs accordingly. How do RCCs balance the trade-offs between accessibility and quality of services? And what are some best practice strategies? And then how do they leverage and diversify their funding and resources? And what are the opportunities and challenges of different funding sources and models? So almost done. Next slide. And you can just keep going to the very bottom, please. So as I mentioned, all these new organizations run, led, and operated by people themselves in recovery is part of a movement that started 20 years ago. And I do interviews with people. I'm doing interviews with people in the movement, and I always ask them this question. I ask them, is there still a movement? Or has the movement evolved into more professionalized organizations that are just subject to the same organizational and market dynamics that all nonprofits have to deal with? In which case, there's been a shift, and we need to adjust accordingly. I have also heard that there is policy inertia happening in the movement. And so how do you reinvigorate a movement when there's this sort of inertia? Or maybe there isn't a movement. I don't know. But the question is, where is all this going? Will this movement lead to PRS just becoming an adjunct to the medical system and lose its mutual aid orientation? If so, I think that a lot of the activists from 20 years ago would consider the movement a failure if that happens. And so I'll leave with this one question, which is, what is the role of RCC leadership in helping to avoid that risk and addressing some of the issues uncovered in the FVR report? And so that's an invitation to recovery community organizations and their leadership to be involved in helping to address some of these issues in the report. So I'm looking forward to your questions.
Wonderful. Thank you so much, Ken. That was great. I haven't seen in the chat any burning questions, but I'm sure you all are just formulating your thoughts right now. So while you're thinking about the questions to ask, let's go ahead and have Brian and Sarah react with their thoughts, and then you have a chance. So thank you, Olivia, for advancing the slides. So we have with us Dr. Sarah Duffy from the National Institute on Drug Abuse, who is one of the main reasons we are all here today, because she really has championed this cause of advancing the science and recovery support services. And then Brian Robbins needs the introduction since you just heard him. So who would like to go first, Brian or Sarah? Who we have? Oh, thank you.
First.
Sarah, floor is yours. What's your reaction?
Thank you so much, Brian. And thank you so much, Ken, for this great presentation and the thoughtfulness and the broad-ranging approaches and a bunch of great research questions. And what I would like to...
and can we stop screen share so we can see each other? Sorry, Sarah.
That's okay, no problem. And what I would like to really address are sort of NIDA's interest in recovery support services and research around that. And I think it's really important to note that it is specifically within NIDA's strategic plan to address these issues scientifically. And specifically, some of the things that Ken mentioned, understanding the mechanisms of how these approaches work. And Brian had mentioned, an important pathway for one individual. And there are different pathways for people. And is there anything we need to learn about how to help people figure out which pathway or work with people in different pathways, that kind of thing. Also, there's a broad range of outcomes that can be addressed. Ken also mentioned research methods. Are there research methods that need to be developed that can really help us understand these programs? And one of the things I was very excited about when you guys did the poll questions was that you're interested in scientific research and how it can really inform all of those questions that were in the polling. So I thought that was great. What about sustained recovery? Are there things that really need to be done to advance that? And so I think those are just some of the questions that are in our strategic plan that really, really speak to some of the things that Ken had said. The other thing to note is that Our strategic plan comes out once every 5 years, and the world changes, things happen. So there are a couple of other places to find our priorities. One of the really neat ones is to look at our Institute director's blog, Nora's blog. She often writes about things that are top of mind for her, and that's a good place to find things out. Another place is we have our National Advisory Council on Drug Abuse, and they meet 3 times a year. And for each meeting, we propose just sort of a basic idea, a concept of things we're interested in. And then they say, yeah, that's a good idea or not. And those are all listed on their website, the website for the National Advisory Council. And so you can get an idea of what we're interested in. Now, it's not guaranteed that there'll be any kind of initiative or anything coming out with that, but at least it gives you an idea. And the other place, of course, to look is the NIH Guide to Grants and Contracts. You can look at everything NIDA is interested in, and I would say NIAAA is also interested in this area, and probably other institutes, to see what's coming up there. Those actually are notices of funding opportunity and that kind of thing, notices of special interest. And one of the things to know is that because of this interest in recovery, and really because of the work of you all out there in raising this as a legitimate and important potential for people with these disorders, most of our funding opportunity announcements from my branch, the Services Research Branch at NIDA, actually include recovery support services and recovery as something we're very interested in. That didn't used to happen. And when we started with the opioid epidemic and really focusing on that, it was really, let's get people into treatment. Let's do harm reduction, those kinds of things, all important. But then, I went to a meeting with John Kelly and others at SAMHSA. SAMHSA, of course, has championed this for a long time. I was like, wait a minute, we're going to have lots of people who have opioid use disorders who maybe would like to maintain their medication or not, whatever their pathway is, but who are going to need support. We can't just get them into treatment and then you're done. It doesn't work like that. And those of us who have had family members with some of these disorders know that it may not be for some people a straight shot, and we want to be there to provide support wherever they need. And so I believe that lots of stuff is going into the chat in terms of links for specific funding opportunity announcements, and also our notices of special interest. So I thought, now I want to hear what all you guys have to say, so I'm going to be quiet now. Thank you.
Thank you so much, Sarah. Any questions for now, or shall we go over to Brian? Let's hear you from you, Brian, and please, everybody, just raise your hands, start talking. We want to hear from you. Brian, go ahead.
Yeah. So once again, thanks for having me here. And Kenneth, there was a lot that went through in his presentation, and I was writing down some things, and that just popped into my mind. And one of the biggest things that I have found, so I've been working in recovery support since early 2000s, and today I work for traditionally an RCO, and it's not always been that way. I've worked for organizations that did treatment and prevention, and wanted to get into building recovery community centers in different places and spaces, and it wasn't until I came to CCAR that I realized the difference of what that was about. Kenneth talk about who's making these decisions, right, for these recovery community center and or the participants in those centers, and today it's much different, and I know that there's a few people that I've worked with in Massachusetts here, because I scrolled through you guys' list, and I've seen a couple people that I've worked with in the past, and it's great to see them here. And the difference is night and day. So I from a personal standpoint, you know, I had a conversation with my executive director around, you know, where we're moving with our recovery community centers, and we're a coaching organization, right? So I always feel supported. I'm not supervised. I'm coached in my role, you know, as the program manager. So I'm not even speaking about like a recovery coach working with a recovery. I mean, our staff is coached also. So when there was, you know, things that came up around how we're moving forward with the structure of our recovery community centers, he didn't tell me how he wanted them. He asked me how he could support me to do what I thought was best for those centers, because that's why I'm here. He said, if I had to make these decisions, if I wanted to make these decisions, I wouldn't have you here in this role. You're here because I believe in the work that you do and in your experience in building these centers. So for me, that's like the difference when we talk about that workforce, right? And how we're supported. You know, when we first implemented recovery coaching in Massachusetts, you know, there was a lot of discussion around who's going to supervise these coaches. So they had clinical supervisors supervising recovery coaches at one point in time. That absolutely did not work, right? And then they developed this training to help support these clinical supervisors so that they can try to understand, you know, the role of a recovery coach. And my opinion, it still did, you know, it is what it is, right? So, you know, so I've been on both sides of the road there, and I truly feel today that I have I have never felt so as supported as I do today in working in the organization that I work with. And you know, the other thing that really struck me, and it's because it's what we're doing right now, it's actually where I'm sitting right now, is we talked about locations of centers, right? So we at CCAR in Connecticut are moving our centers out of, you know, out of the middle of the suburbia or off the back roads of a city and into corporate buildings. I'm sitting right now in downtown New Haven on Temple Street, which is like sitting in you know, downtown Boston on the third floor in a corporate building where this recovery community can come together. And I have placed my other center in Hartford in the same type of location. And what that has done, not only for the participants, but for the community itself, is amazing. Because corporate America, in their, you know, in their bubble or whatever, you know, a lot of these people in these buildings have no idea what we do in these centers, and now they are stopping in. They're curious because they hear laughter in the hallway. They're curious because they see people outside taking care of the community, cleaning up outside, you know, or doing whatever in their community, and they're just curious, and they come in and they're like, wow, I never knew what went on inside these places and spaces, you know. And so I think that it's very important about where we locate our centers. And we're not, you know, we're not meant to be hidden from society. That I believe that we should be right. We are society, right? And we should be in these places and spaces that can only enhance you know, the community that we're in. And on top of that, the volunteers and participants are so proud to be. So I walked my the volunteers and participants had their first walkthrough of this center. They haven't seen it. I mean, I've had this lease going. We did a whole build out inside. We're 5,200 square feet. You know, we have multiple rooms and offices and group rooms, and tech and everything had to be brought in. And they walked in, and if you could have just seen the look on their faces when they seen this space, from where they came from, it was amazing, you know. And just to speak a little more about the location too, and there is a little bit of a strategic aspect to it, because I've also embedded all our recovery support services within the centers, meaning that all our emergency department recovery coaches and our Department of Correction coaches and jail diversion have space in each one of our centers. So that because I believe that the Recovery Community Center is their greatest resource, but we've also put them close to the places and spaces that they work and where they do their support. So around the hospitals that CCAR in Connecticut is in every hospital in Connecticut. I believe it's 32 of them. We just finished that up this year, and we're in all the prisons in Connecticut. So the movement, part of our movement of our structure changes is that we're putting our centers in these corporate type spaces and close to the places where we do our best work. So, and I think that that's very important, you know. So I'm really enthused to hear some feedback from some others, and can't wait to see the questions and hear the dialogue and the conversation that goes on with the rest of this seminar.
Awesome. Thanks, Brian. So who has a reaction, thought, question?
I see Niles Comer has a question about funding sources for recovery RCOs and RCCs, and maybe that's a Brian question. I know that a lot of RCOs and RCCs use braided and bundled funding, so they basically bring in multiple sources of multiple grants together, and very few of them, submit bills for reimbursement for Medicaid. Most of them are grants. So Brian, if you want to chime in about that, since that's your bailiwick.
Sure. So for us, it's a little different. So in our RCO, a lot of our training, our recovery coach training academy, our ethical consideration trainings, and all the trainings that CCAR provides funds a lot of the work that we do. So a lot of it's in-house. You know, there's some of when we're speaking about RCCs, right? So they do receive some funding from DEMAS, which is some state funding, but out of the 5 centers that we have, three of them receive some a little bit of DEMAS funding, and then the other 2 are funded through CCAR itself, through their training department. So we're not tied to a whole lot of line items and things like that we must have to obtain to or anything like that. But there is some other grants that we work with, like we do some work with some problem gambling in Connecticut. So we have some small grants that come into our centers to help to provide that support and things like that. But as far as that's my gist of the funding stream for us. And really our executive director handles all the budgets throughout the organization. So and while I was in Massachusetts, I had to oversee a lot of that kind of work, but in Connecticut, it's different. The ED handles all the budgeting.
Question. And Rachel, I think Ellie probably already told you, yes, we will email everything out that we have here. So I was curious, so, Ken raised the thought of like, is the recovery movement stagnant? Is it still growing, or where is it going? From a science perspective, for me, it feels like it's going through an explosive growth phase. And I'm curious if Sarah feels the same and other scientists in this room feel the same. There's so many questions we have. I think Ken did had a great list of so many questions that I want to dig down on. So I think from a scientific perspective, it's explosive, and I'm excited to dig in. I'll mention that one of my favorite announcements that are in there is a secondary data analysis announcement that's existing, because I know so many RCCs are collecting data and have a lot to draw on. And if there's a way that we can help in making connections or partner with you on working on one of these NIDA grants to utilize your data, just give us a shout and we'll be happy to do that. There's a lot of other opportunities too, but that's one of my favorites out there. What do the rest of you guys think? Stagnant, growing? What do you all think? Where are we going? So we have Rachel and Wilma chiming on growing. If you're comfortable to just kind of share like what's going through your mind when you're thinking and saying growing?
I can share. It's fine. When I say growing, I'm in Texas. I'm Rachel Labus, and I'm thinking of opening. I'm not thinking. I am in the process of starting my own recovery center.
Awesome.
Eventually, Fort Worth is really lacking in those resources. Fort Worth, Texas. Dallas is a little ahead, but San Antonio, Austin, Houston are really great examples of the growth spurt. It just takes a few to really get that momentum going. So just gathering the people who are excited about bringing that recovery center and into the Fort Worth area. So I think Brian is his name. I want to come visit your place so I can get some really great ideas. Thank you.
Welcome anytime.
Oh, one other thing I wanted to say too is like there's a great push for peer support specialist training. They're really, really pushing. So anyone I see, I'm always recommending certain scholarships and classes because we're in Texas, they're really trying to pump up the numbers. We're kind of lagging behind other states. So it's growing.
As for me, the reason why I say growing is because we have the pleasure that we open another recovery center in Farming. Today is the ribbon cutting, and so I'm very, very grateful, very excited. Excited for the community of Farming that is in need of it. And not only that, the services that we provide for the community, we're involved with the whole community, including the police stations, city hall, DA's office, recovery for incarceration, and what's so not. So they validating and they seeing the work that we're doing, and the more collaboration, the better.
That's awesome. Congratulations on the ribbon cutting. That's amazing. Pablo.
Yeah, for me, I know when I started doing recovery coaching, there was only 5 peer recovery support centers in Massachusetts. And it went up to 27, and there's now 40-something peer recovery support centers. So I know that the movement is growing and that we're doing something right over here in Massachusetts.
So true. And that's a great thing about being able to network across states, right? So there's a lot of expertise in some states who've invested early, and then for states that there is less, they now have people to reach out to and saying what worked and what didn't. So that's always a great way to help each other across the state lines. Go ahead, Wilma.
Not only that, it's a new approach. Treatment facilities, something that's where I come from. We're in the area of Brockton, so I'm from Boston, and I relocated. So this was totally new to me, and it's awesome how the peers to peer level, and they could communicate with each other, help each other, and embrace. And I also compare treatment and recovery, as you said, to a flower or a plant. How you treat it, how you nurture it, and then how they gain the housing, they getting their license, they having a job, and I see them coming through the doors laughing and, well, I got it, and I'm like, yes, you got it, of course you couldn't do it. So sometimes what the community needs, somebody to give them a little push, somebody that care, somebody that look at them with empathy and sympathy and be able to connect.
Yeah.
Yeah, I got a little story, so Wilma brought up Brockton, right? So that's my hometown. That's my hometown. And his big boss is one of my mentors. So I was doing HIV work in Brockton, and when that center first opened, And I used to go over to that center, and I didn't know what a recovery community center was about. This was like 2005, 2006. And I started to develop a relationship with Efrain Baez, who was the director over there in that center. And from that, Efrain wore me down and had me come to work for him. So I started as a volunteer at Stairway to Recovery. That's his center. You should have said the name, right? Stairway to Recovery. I started as a volunteer going to 12-step meetings there, ended up working there, worked underneath his big boss for years, right? And then from there, built that center in Hyannis, and then also built another one in Plymouth, and now they're opening up that one in Falmouth. So I'm still connected to them guys. They don't. Wilma doesn't know it too much, but I stay on top with them. And so I am a perfect example of like what can happen when a peer comes into a recovery community center. So I've worked my way from working on the floor in that center where his old location was, to being the assistant director, the director, directing multiple centers, and now out into CCAR, overseeing all the recovery centers in the state of Connecticut. And I was just somebody seeking recovery.
Good work, Brian.
Yeah.
Yes, indeed. Brian, my apologies. Yes, indeed. I have heard so much about you. So I'm grateful to put a name to the face. So therefore, please, I'm gonna put my email in the chat. Please reach out. Yes, and you know, it's a pleasure for me to be in front of all of you, the doctor, Kenneth, you know, and stuff like that. And you know, let's continue doing the great job that we're doing for our community that is in need of it.
Sure. We are at the top of the hour. A couple of us had to leave. The presenters are going to stick around until 1:30, so we can have some more discussion and thoughts. But I did just want to say before people have to leave, thank you guys for being here. Thank you for sharing and actively contributing and supporting one another. It's always wonderful to see you. We're going to end the recording here, but we're going to keep discussing until